Good morning. I have one job this morning, and that is to persuade you that we need to do improvement differently. We need a different way if we're going to have different results. And I said to you yesterday that despite almost 14 years of increasingly intensive efforts to improve, and we have made progress, and I don't want to minimize the progress that we've made, but we still have instances like this one. Hospital near Atlanta needed to notify 456 patients that the procedures they had were done with colonoscopes that were not cleaned properly, and they might have been exposed to hepatitis B or C or HIV. Maybe this was an instance where a tech in sterile processing saw something and didn't speak up. Hospital near Pittsburgh notified 141 patients that they had coronary artery stents put in for absolutely no good clinical reason. And this is one of the few hospitals that had the courage to ask that question. We set fire to patients in our operating rooms about 600 times a year in the United States. And despite about 20 years of trying to get rid of wrong site surgery, this is a hospital near St. Louis that operated on the wrong side of a patient's brain. Hospital I used to work at Mount Sinai, took out the wrong kidney on a patient. And this happened in the UK to remind you that these problems are all global. In this case, surgeon was operating to take out a severely diseased kidney. A medical student in the back of the operating theater said, "Doctor, you're taking out the wrong kidney." The surgeon proceeded, took out the healthy kidney, and this patient died 5 weeks later. This one caught my eye a few months ago in Florida, where a surgeon did a vascular bypass on the wrong leg on this patient. After he finished that procedure, it was pointed out to him that the patient really was scheduled for the other side. He went and did the other side, and then the next day went to visit the patient and asked her to sign a consent form for the wrong side because he said she needed it anyway. It's not a HIPAA violation, it's in the news report. So I think that it's fair to say that after all of this, as I said, increasingly intensive effort to improve quality, we still see that routine safety processes fail routinely. Best global number on hand hygiene in hospitals across the world, a meta-analysis of dozens and dozens of studies, shows that hand hygiene fails in hospitals 60% of the time. Handoff communication fails 40 to 50% of the time. Wrong site surgery occurs about 50 times per week in the United States. We need a different way to do improvement if we are going to get to zero. And what I want to talk to you about in the next few minutes is the beginnings of an understanding of what that different way might be. I talked to you yesterday about high reliability organizations. Liam Donaldson reinforced that message. This is a study of organizations like commercial air travel, nuclear power, that really have figured out how to maintain exemplary safety records. And one of the things I wanted to comment that I didn't mention yesterday, another characteristic of these organizations, if you look at US commercial airlines, in the 1990s, they had the best safety record on the planet, 14 deaths per million flights in that decade. What happened the next decade? The next decade, deaths per million flights fell by 89% to 1.6 per million. Why did they do that? They were already way ahead of every other country in the industry, because it's a characteristic of high reliability organizations that they are never satisfied with where they are at any one point in time. They are always striving to push the envelope further, indeed to get to zero. So, as I said yesterday, we have spent a lot of time with these experts over the last 4 years working with hospitals, a small number of hospitals and systems that have committed to the goal of high reliability, to getting to zero harm. We've created a model for what healthcare ought to be doing in order to make much more rapid progress to get there. And these are the three components. The first is a leadership commitment to get to zero. We talked a little bit about that yesterday. We talked a little bit about a culture of safety. A lot of folks over the course of the last day and a half have talked about the need to change culture in our healthcare organizations. And let me just take a couple of minutes, because I'm going to spend most of my time on the rest of the morning on my remarks on RPI, this new way to do improvement. But let me frame a couple of issues around safety culture. The first one is we've talked a lot about how we need to get frontline caregivers to tell us when there are problems, to point out weaknesses in safety procedures. And in order to do that, we can't blame them, we can't punish them. And in many organizations, that's taken the form of a desire to have a completely blame-free culture. How many of you are familiar with that phrase, blame-free culture? Right. I can tell you unequivocally that there is no high reliability organization on the planet that has a completely blame-free culture. What they have is a way of looking at patterns of errors and mistakes and behaviors and understanding which ones are blame-free, should be treated as blame-free because they're innocent mistakes. They're the small mistakes that people make largely in healthcare because we put them in processes that don't work. But they also have a process for transparently, equitably looking at patterns of errors and behaviors that do need to be dealt with by discipline. So it's a balance between learning from blame-free errors and holding everybody accountable for adherence to safe practices. So a number of the hospitals that worked with us on our hand hygiene project that I'll be talking to you about in a minute, in addition to making it easy to do the right thing, to wash your hands, also found that they had to introduce the disciplinary track for those folks who were repeated offenders and who refused to comply with these safety protocols. So it's a balance in establishing a truly safe culture. And the third component is very effective process improvement. That's the new way to do improvement that I'm going to be talking about for most of the rest of the morning in my remarks. And it's very gratifying to see that there are now a growing number of hospitals and systems that have explicitly committed themselves to the goal of high reliability, to ultimately getting to zero harm. We've written up this model in this article. It's on the Joint Commission website, and I'm happy to talk about it in more detail. What it does is to talk about the components of leadership, the components of safety culture, the components of robust process improvement, and how an organization moves from beginning this journey to high reliability to getting closer and advancing and getting further along. We've created tools and programs to help organizations that want to do this, including a self-assessment tool that allows a leadership team to figure out where they are on all of the components. There are 14 in all of high reliability. And we have a statewide initiative underway today in South Carolina working with 21 hospitals in partnership with the State Hospital Association that have used this tool to understand where they are with respect to their goal of getting to high reliability and where they need to focus in order to make the most progress in the coming months and years. And all of that is in here and on the Joint Commission website. So what is this new way of doing improvement? Well, it's not mysterious. It's tools that have been used in industry for several decades, only now starting to penetrate into healthcare. Lean, Six Sigma, and change management together, 3 complementary sets of tools, each with slightly different emphases, slightly different capabilities. They all need to be used together. And what we are about at the Joint Commission is we've adopted all these tools for our internal improvement purposes. We use them to improve our processes as a business and relate to our customers, understand their needs, and satisfy them better. We are adopting all of the components of a safety culture, and we measure how well we're doing in targets set by our Board of Commissioners, and we report those as part of our strategic dashboard of metrics that we report to our board. So that's just to say that we are walking this walk as an organization as we are exploring with healthcare organizations how they can do it in their business. We created the Center for Transforming Healthcare so that we could take these tools and partner with hospitals and health systems throughout the country that have also mastered them to bring them to bear on these very difficult, persistent quality problems to see if this new way of approaching quality problems could produce much better results. We deliver the products of the center, and you've heard about the TST, the Targeted Solutions Tool. I hope many of you have visited the demonstration. All of the products of the center are being delivered to accredited organizations as part of accreditation for free, no added cost. And in the first 5 years of operation of the center, these are the difficult problems that we have tackled with teams from hospitals all across the country that have mastered the tools of Lean, Six Sigma, and change management. And this is the roster of 26 hospitals and systems that are partnering with us, and a number of them are represented in this room. And you'll see some of the usual suspects on this list, but you'll also see some hospitals like Wentworth Douglas, which is a 120-bed hospital in the seacoast part of New Hampshire. Small hospital, they have a great RPI program. And by the way, it delivers a financial return on the investment for learning these tools of 3 to 1 that they've measured, that their CFO has measured. So this is a very effective and broadly effective set of tools, not only for clinical quality and safety problems. So if we look at these problems and we say we're still stuck with these problems, after 15 years almost of intensive effort, don't we have to question the way we have been going about doing that improvement? And if you look at the way we do improvement, I'm oversimplifying a little bit, but not too much. We typically get a group of experts around a table. They're saddled with piles of evidence. They review the evidence of a particular problem and what the approaches to solution are. They come up with the evidence-based best practice. We translate that into toolkits, bundles, checklists, protocols, and then we say to everybody, do it this way. It's a one-size-fits-all approach to getting rid of safety and quality problems, and you do get improvement that way, but it is modest. And it's difficult to sustain, and you can't get to zero that way. The one-size-fits-all approach works really well only when the problem you're trying to solve is very simple and when it doesn't vary very much from one place to another. None of the problems on the previous slide are simple. So what is this different way? What does it look like? Well, it first requires a recognition that complicated problems, and it turns out even something as seemingly simple as hand hygiene compliance is fiendishly complicated. I'll show you why in a second. Those kinds of problems require more sophisticated approaches to problem solving. And when we apply these tools of RPI to these complicated problems, we have found 3 things consistently every time. And if you don't remember anything else from what I'm telling you yesterday, day before, today, these 3 things I'd like you to remember. The first finding is that when you look hard at why hospitals or ambulatory surgery centers or wherever you're trying to solve a problem, why the organization has a problem with hand hygiene compliance, it turns out there are lots and lots of reasons. The harder you look, the more causes of the problem you find, 20, 30, 40. Each one of those requires a different intervention to get rid of it. And the kicker is that when you look in one place, when you look at one hospital unit, when you look at one nursing home, you don't find all 20 or 30 causes. You find a few. You find 5 or 6 that explain typically 70 or 80%. The top 2 typically explain 30, 40% of the problem. So you can package a small set of targeted interventions, carefully addressing the most important causes in one location and have a huge impact. But the kicker is that when you move to the next place and look at their causes, they're different. The key causes differ from one place to another. So when you apply the same set of interventions designed to solve 3 or 4 specific causes in places that don't have those causes, that's why the experience throughout the hospital industry is when I try somebody else's best practice, I get a little bit of a result, but it wasn't what I was expecting based on that great report. RPI is producing the next generation of best practices, ones that lead to a set of solutions that are targeted to the causes of the problem that you have where you're trying to fix it. Now, I don't have time for a lot of examples, but let me give you one. First project we did with the center was to improve hand hygiene. It was selected actually by the first group of 16 hospitals that we had recruited to partner with us because that was the #1 problem that they said they wanted to solve for themselves. And here are 5 of the top 20 causes of hand hygiene failure. #1 was actually really common. Almost all of these hospitals thought they were at 80, 85%, and when they looked, they were washing their hands less than 50% of the time. And Tom Prislak, who's with us today from Cedars, Ron Peterson from Johns Hopkins, got up at a national press conference when we launched the center with these results and said, we're washing our hands less than 50% of the time. We need to do something different. If you look at each of these causes, it's easy to see that each one of them requires a very different intervention. If you've got bad data, you need to collect good data. If you don't have the hand gel dispensers in the right place, you need to put them in the right place. But even if you have them in the right place and you have a maintenance program that doesn't keep them always full of hand gel, it doesn't matter how many hand gel dispensers you have, you're going to have poor hand hygiene. So lots of causes. These are 5 out of 20. Each one requires a different intervention. And here's the evidence. All this is from the center's website, and this has been published. This will be published later this year. Each column here with a letter on top represents one of the original 8 hospitals in the center. Each of the rows is now the top 10 causes of hand hygiene failure. And an X in one of those little boxes means that the RPI statistical tools prove that that was one of the key causes of hand hygiene failure in that organization. Look at how different the pattern of causes is. And let me make one more point about this approach, this different way of doing improvement. We could have said, now that we've studied this problem in 8 hospitals, we've got the top 10 list that needs to go into your best practice for hand hygiene improvement. Everybody develop interventions on all 10 of these causes, and you'll solve your hand hygiene problem, right? But now look at Hospital A. What would have happened if Hospital A did not know what its specific set of causes was and it implemented this 10-step best practice? It would have been wasting 40% of that effort in the causes in those circles because they didn't have those problems. So this approach to improvement is not only highly effective because it identifies why you have the problem and allows you to target interventions precisely, it's also very efficient because it doesn't lead you to waste resources on the causes of a problem that you don't have. We have used this approach on all of the problems I showed you on the center slide and found absolutely the same results. All three of those characteristics. Now, what happens when you develop and deploy targeted interventions to those causes? What you find is major improvements. The first 8 hospitals that did the hand hygiene project improved hand hygiene by 71%. The handoff communication project reduced failed handoff communications by 56%. The wrong site surgery project started out by saying, we need to look at the entire surgical process, not just what happens in the OR, and found that 39% of cases, all cases in these 8 organizations, had risks for wrong site surgery that were introduced when the procedure was scheduled. And more risks piled up as the process went on into pre-op, and more risks piled up in the operating rooms, to the point where, in some of these cases, the operating room team was so set up for failure by the cascade of errors that preceded them getting there that it's amazing we don't have more of these unfortunate events. But this targeted approach led to reductions in risk in all of these areas, 46, 63%. Colorectal surgery, surgical site infections fell by 32%, one of the most resistant of the surgical site infections, extremely common, huge variability. This approach works to produce dramatic results. And just one more time, these results are very consistent because they allow you to identify exactly what your causes are, target interventions to those causes, and that leads to very efficient and effective solution sets that eliminate this one-size-fits-all problem. And it doesn't matter, so far, which of these difficult problems, including inpatient falls, which we'll be talking about publicly, the findings in the next couple of months. And as I have looked around the world, there is no other organization except the Center for Transforming Healthcare that is deploying this capacity, RPI, to produce this kind of generalizable knowledge about how to get major improvements in clinical safety processes that now routinely fail 40 to 50 to 60% of the time. That's very nice, and we're very happy about that. But there was another challenge that we set for ourselves in creating the center and in doing all this work. And this is the second feature of a different way to do improvement. And that is, how are we going to get this information to the 95% of organizations, hospitals and other organizations, that don't know what Lean Six Sigma Change Management RPI is and aren't likely, despite our constant urgings, aren't likely to get that capacity anytime soon. And this is characteristic of the problem with collaborative quality improvement. We've seen 25 years of collaborative organizations getting together, trying to solve problems, making progress, and the progress and improvement stays within that group of organizations. There are very few exceptions to that. Peter Pronevost's ICU central line infection project is the only good example of an effort to spread effective interventions beyond an initial collaborative group. So we set for ourselves that challenge, and the result of meeting that challenge is the Targeted Solutions tool. The Targeted Solutions tool is a set of web-based tools that is available, as I said, to accredited organizations today as part of accreditation. There's no added cost to get into it. It's on their Joint Commission extranet site right now. It's entirely voluntary. It is separate from accreditation, so all the information about wrong site surgery or hand hygiene that goes into the TST is entirely confidential, totally separate from accreditation, so you don't have to worry if you're a hospital and you discover your hand hygiene compliance rate is 40%. That information is not going to the surveyors. But if a surveyor happens to show up and sees instances of hand hygiene noncompliance, a really good response to that surveyor would be, we're using the TST to improve, and here's our plan, here's our data, here's how we're rolling it out. We have taken all of the Lean Six Sigma change management jargon out, and what's left is a step-by-step process that any organization with a basic performance improvement capacity can use to walk through each of the steps of the original project, from very accurate and reliable measurement, bringing that data back to the TST, looking then at the TST to figure out what your causes are, bring that data back, and you get a list from a pull-down menu of all the interventions with step-by-step implementation guides to how to deploy interventions proven to be effective when they're targeted at the causes that you decide you want to tackle because you've seen which ones are the most important to get rid of the problem in your organization. Right now, there are 3 modules in the TST: hand hygiene, wrong site surgery, and handoff communication. You'll be hearing from folks that have used those in the panels to follow today, the hand hygiene and handoff communication, and the others will follow. Now, we know from the data that we've collected, over 1 million observations of hand hygiene compliance in the TST, that if you use the TST and you get the average improvement, which is from about 50% to about 80%, that hospitals and other organizations have used, that your HAI rate will drop by 35% across the board. Whether it's C. diff or MRSA or device-related infections, hand hygiene turns out to be incredibly important in, if it's low, maintaining a high rate of HAIs, and in improving, dropping dramatically. If you're a 300-bed hospital based on national data, you would expect about 550 cases of HAIs. You would have 194 fewer if you got this average improvement from 50 to 80% in hand hygiene. Because these HAIs across the spectrum have a mortality rate of about 6%, you will save 12 lives per year and avoid about $3.7 million in cost. If you're a larger hospital, just double those numbers. Now, that's for the average improvement from 50 to 80%. It looks like there is an important increment above 80%. So if you get to 90%, as Cleveland Metro Health did, over 95%, their bloodstream infection rate fell by 2/3, not by 35%. And here's a hospital that improved its hand hygiene rate using the TST from the 40s to over 90%, maintained that over 2 years, and their MRSA rate dropped by 2/3. And let me finish by embarrassing Michael Shabbat from Memorial Hermann, or maybe not. I don't know. I don't think these slides have ever been as big before when I've looked at them. Memorial Hermann is one of the systems that partnered with us from the beginning in the center. It's a 12-hospital system based in Houston. They committed to the goal of high reliability and were the first to use the TST throughout their system to improve hand hygiene compliance. They won the Eisenberg Award in 2012, and this article in the Joint Commission Journal, if you're interested in learning about their road to high reliability, is very informative. And what they found when they measured, each of those yellow bars is the number of measures of hand hygiene across their 12-hospital system, 150 inpatient units, their baseline was 44%. They rolled the TST out unit after unit, tackling cause after cause, and finally, at the end of December of 2012, got over 90% system-wide hand hygiene compliance. 150 inpatient units, 12 hospitals. And I'm not going to have time to go through a lot of the results, but here's one. This is data on ventilator-associated pneumonia system-wide, all 12 hospitals at Memorial Hermann, starting at the far left of that slide in 2006, high and variable rates before the bundle of interventions was put in place. Then the bundle was put in place in the middle of this slide, and they got a reduction. But it was only after the TST was deployed throughout the system to improve hand hygiene that they got system-wide to 0. And this is only one of a number of HAIs that they have managed to get to zero and stay at zero or near zero since the Hand Hygiene Improvement Project. And Michael has said, we fully attribute to the Center for Transforming Healthcare's Hand Hygiene TST the final drop in HAI rates to zero or near zero system-wide. After implementing the Hand Hygiene TST, our hospitals began to report zeros as their most common monthly central line infection and ventilator-associated pneumonia result. Think about that. Our hospitals began to report zero as the most common result for these infections. Our mothers were right after all. Feel free to quote me, which I'm doing and do all across the country. This actually saves lives. So we're starting to accumulate really good data that there is a better way to do improvement. I believe we have to set much more ambitious goals like this summit is setting to get to high reliability, to get to zero harm, zero preventable deaths. And our current standard approach is not working. It's not getting us there. RPI produces much better results. And we are committed at the Joint Commission to using these tools, to disseminating them to all of the organizations we work with. A lot of this information is free in the public domain on the center's website. We are really grateful to be partnering with Joe and the Patient Safety Movement Foundation here to gain even further propulsion for these ideas. And I greatly look forward to working with all of you to make this goal of zero a reality everywhere. Thank you.